So I think we are live.
We are.
Brilliant. Hello everyone and welcome to the Quality Network for Mental Health Rehab Services first webinar. This is our very first webinar, so this is sort of like a learning process for us as well. So do bear with us if there's any, I guess, technological issues. Hopefully there won't be any, but just bear with us kindly. So my name is Fatima and I'm the Deputy Programme Manager on the network. Behind the scenes, we've got Connor Booker, who's a project officer who will be producing this live stream as it happens.
Hello everyone.
So before I guess introduce you to our speakers, just to give you a bit of a brief background to Ames Rehab, for those of you who haven't I guess worked with us before or are new to the network. So Ames Rehab works with services to improve the quality of inpatient rehabilitation work. We engage staff, service users and carers in a comprehensive process of both self and peer review for the purpose of quality improvement. We encourage the sharing of good practice and high quality care and support services to identify and address areas of improvement in line with our quality standards. We are also currently developing a set of community standards to work alongside our inpatient standards. So I guess the main aim of today's webinar is to continue to share and update you on the wider factors impacting the rehab world. I guess as a network, we have always done things face to face and engaged with our members in the networking capacity. So to be able to do this webinar, to share with you, continue to share with you, is a huge privilege. As a network and a Royal College, we want to do the best that we can to continue to support not only our members, but the wider mental health rehab professionals, enable you to tap into knowledge and experience and best practice to help in this difficult time. Before I pass you to our speakers, just to go through a couple of housekeepings. So this is a live event and you are on mute unless you are a designated speaker. The webinar will be recorded and uploaded to our Knowledge Hub, which is currently only accessible to our members. However, as this video is a public interest, we will also be publishing this on our website, which we will do so as soon as we can. Please use the chat function to ask any questions. If you cannot access the chat function, it would be great if you could perhaps email in your questions to rehab@rcpsci.ac.uk and then we could pick those up as we're going along. So without further ado, please let me hand you over to our speakers, Helen and Sri, to introduce themselves and get the session rolling.
Great. Thanks very much indeed, Fatima and Connor, for putting this together so efficiently and so quickly, and thanks ever so much to everyone who is participating on the other side of this screen. I'm Helen Killaspy. I'm a Professor of Rehabilitation Psychiatry at University College London, and I work clinically in the community in a mental health rehabilitation team in Islington in North London. So I'm just going to talk through a sort of scene setting, a few slides, and then talk in a bit more depth about some of the things that we've been doing in Islington to try and deal with the current pandemic situation. And then Sri's also going to speak after me, and then we'll open it up to some Q&A. So next slide, please. We've got the next slide. Oh, that's not the slide. There they go. Technical hitches were expected, but yeah, Connor, have you got the first slide in my set there?
Sorry, bear with me here, just one.
It was working fine in our practice run.
We've had 2 rehearsals and it's been perfect. There you go. Look, it's not an issue. If it won't work, Connor, just say and I'll just speak.
Is that should be fine there?
Okay, can you press it to the next slide? If that's it, hooray, we're there. Wonderful. So, look, I know it's no surprise to you all to know that the 23rd of March was the day when Boris Johnson announced our initial 3-week lockdown, obviously closure of most services except food shops, and asking us to stay at home unless we really had to go out, being allowed only to go out really to get our food shopping in for an hour of exercise per day, working from home obviously wherever possible, and the guidance around social distancing when out and about to keep at least 2 meters from people who you don't live with. And he also of course mentioned the fact that the police had powers to try and enforce the guidance and disperse groups of people that might be gathering in public spaces. Next slide please. That self-isolation guidance is now very familiar to us. Anyone with any symptoms of COVID has to self-isolate for 7 days, and anyone who lives with them should self-isolate for 14 days. And then there was also guidance for people over 70 or people with underlying health conditions to be shielded, in other words, to self-isolate for 12 weeks. And that initial list of the underlying health conditions was updated a few days later and now encompasses around 1.5 million people across the UK. Next slide, please. So this is a table showing the rather grim kind of league table of COVID cases and deaths globally, and these data are from Wednesday, but on Wednesday the UK was the 6th highest in terms of total cases and total deaths, the 5th highest in terms of deaths per 1 million of the population, but the 11th highest in terms of completing tests per million of the population. So, and as we know, there's been a lot of attention in the media about getting tests scaled up. Next slide, please. When we look at that in more detail, particularly thinking about deaths, most of those have been in London, but the Midlands is another hotspot. Wednesday was important as well because it was the first time that we had data published on community deaths where there was any mention of coronavirus on a person's death certificate in the community, and you can see that blue line on the right-hand graph there. It almost doubles the number of deaths when you take account of those kinds of community cases, and obviously as the reporting of that improves, I think that figure is going to sadly go up. Next slide, please. Of course, we've heard about some of the big national responses, the development of NHS Nightingale and similar facilities across the country. Next slide. And the initial guidance that came from mental health services, of course, was similar to that for everyone else, working from home, trying to use teleconference and video conferencing instead of face-to-face meetings. Obviously, social distancing and self-isolation applies to us and our patients the same as anyone else. A lot of work on the use of personal protective equipment and also thinking about how to make sure that staff stay well and keep going, in other words, working with staff on wellbeing as well as physical health to keep the workforce going. The particular things, of course, that are also relevant in mental health services are to do with our legal powers, and we've had guidance around moving tribunals and managers' hearings to telephone rather than face-to-face hearings. In fact, where I work, that's only really been the case for managers' hearings. All tribunals have simply been postponed, and waiting in the wings are possible proposed changes to the Mental Health Act, which are not legal as yet in case that they can be brought in case of medical staffing becoming so stretched that we have to think about having fewer people involved in detaining individuals. Next one, please. I work in Camden and Islington, a trust in North London that covers a population of about 500,000 people. We've got 2 main inpatient sites with over 200 beds, but 97% of our services are community-based. And I work in one of the community teams, the Islington Community Mental Health Rehabilitation team. Next slide, please. So our trust at the organisational level has been in gold command for some weeks, obviously making sure that everyone who they work with understands the national guidance on self-isolation, social distancing. They've been very good at communicating on a very frequent daily basis, having regular teleconferences to update us on the situation and new guidance. They've put in place processes for reporting suspected cases. They've been updating the guidance on the use of PPE and making sure that we're getting hold of supplies as quickly as they possibly could. Also, incredible work around enabling people to work from home, getting all the equipment in place and making sure that people were able to use the software. They've designated now 2 inpatient wards for COVID cases, and also changed our recovery centre into a new psychiatric assessment centre to divert people away from A&E who are in mental health crisis. And that was amazing. It was set up really within just a few days. For our community teams, they've asked us to organise rotas to minimise the number of staff in a building at any one time, and to make sure that the staff are covering essential tasks. Also, of course, minimising any of our usual face-to-face meetings. Some staff have been redeployed to other parts of the service. Medically, we've had to change and update rotas to make sure that we're covering all the gaps in medical staffing, and I'm sure that's true across all staff groups. And in terms of wellbeing, as well as being highly supportive, they've also been doing nice things like making sure that staff get food, pizzas, and I got an Easter egg on Tuesday, and that was very, very welcome. Next slide, please. This is a slide that I actually just got from Twitter, which I thought was a really useful depiction of what we need to be considering when we think about how our services, and particularly mental health rehabilitation services, need to plan not just for now, for the immediate situation, but also for the future. And what you see here is this sort of first wave of, we're in it still at the moment, where there's an awful lot of obviously activity and focus and need for focus on dealing with people who are physically very, very unwell. The second wave is the impact on people whose usual urgent care isn't happening. And the third wave is the impact on people with longer term conditions who are also having their usual care interrupted. And I think that the mental health rehabilitation group really sit in that longer term conditions group. And the fourth wave is the potential for the impact psychologically and in other ways on the general population due to all of the socioeconomic factors that we're hearing about a lot in the media. So I was just going to talk a little bit more about what we've been doing in our services. I think in the first week when the lockdown started, we did a lot of thinking. Obviously, everybody was kind of shocked and trying really to accommodate and to assimilate the guidance and think how this could be interpreted within their particular setting. And what we became aware of course, immediately, and obviously know, is that our particular service user group, people with severe and complex mental health problems, mainly psychosis, had a lot of difficulty really taking in all of this information. They also often struggle with activities of daily living, struggle with self-care, with cleaning and hygiene. And so there was a lot of work done to try and impart the messages that we were needing to impart around social distancing and self-isolation. And that really took an awful lot of consideration, a lot of conversations with individuals. We were very aware that people, when going outside, were of course seeing a lot of the members of the public wearing masks. Over time, I think that the sort of alienation of that initial situation has been gradually taken on board, because everyone, service users, the rest of us, everyone is seeing this everywhere. When we go to the shop, we're seeing social distancing enforced. We're hearing about it on the news all the time. So I think in some ways those sort of initial conversations about social distancing and self-isolation have sort of got easier, but we're still left with the difficulties that it is very, very hard for some of our service users to be able to work within those kinds of guidelines, and I'll come back to that. It's also the case that if somebody is self-isolating and we're needing to take over day-to-day tasks, for example, doing their shopping, it kind of undermines the whole ethos of what rehabilitation is about, which is about helping people who often have very significant functional impairments to be able to gain or regain those skills. And so it kind of pulls in direct opposition to the usual culture of a rehabilitation service. And alongside that, the kind of imposition of rather authoritarian guidelines is also very alien in rehab services, probably in most mental health services, where we try and work in a very individualised and collaborative way with people. So all of those were sort of challenges that we've had to work through, and we've done that really through a whole range of different ways. First of all, setting up forums. This webinar today is one of those forums where we've been trying to share experiences and learn from each other, and to think how we can pull together some of the common themes into some helpful guidance. We don't want to give more and more and more guidance, and so we've been thinking, how can we do this in a way which is quite considered and practical, but also where we're not going to have to keep updating it day after day after day, because actually people are certainly beginning to get sort of guidance exhaustion. So having forums to share is important. At the local level, those forums obviously can be teleconferences, video conferences, whatever is possible. And I think those local forums have been really, really important, because what we've learnt, again, really rather quickly, is that in order to implement the national guidance on particularly social distancing and self-isolation, you have to interpret that at the local service level and at the local service user level. And what I mean by that is that in our setting, for example, in a community rehabilitation team, we're working into a lot of supported accommodation services. Those are run from all sorts of different buildings. Some provide support to people in self-contained flats or bedsits, and that makes the whole process a lot easier, but a lot don't. A lot are working from converted buildings with communal facilities, and trying to therefore define what is a household was one of the first tasks. If you have subdivisions into flatlets, it can be easier to support people around self-isolation than if the whole building is a communal setting. People have got into lots of detailed conversations about how you might do social distancing in communal settings, for example, closing off communal areas. I think that has some potential challenges if it actually means that people end up gathering in even smaller areas in corridors or areas where they can't keep 2 meters apart. So each of those buildings needs to be thought about individually, but then the actual implementation of a self-isolation process for an individual with symptoms or who's self-isolating for other reasons also has to be translated to that individual service user's situation, their ability to understand the need for the guidance, their ability to work alongside it. And a lot of the work over the last 2-3 weeks has been many long, complicated conversations where we've just had to keep trying different sorts of strategies to try and help think through how we can best do that for specific individuals. And I can't say we've got all the answers to that, but we have tried lots of different things for different individuals. Our community rehab team set up a WhatsApp group immediately within the first week of all of this, and that's been really essential for keeping in touch, for making sure that everybody knows where everybody else is, making sure that all the daily tasks are being attended to. And also just providing morale support, having a conversation, having a bit of a laugh sometimes when things are feeling a bit grim. In terms of essential tasks, the sort of face-to-face contacts that our community team are limited to are visiting people to administer depots, to take bloods for those who can't attend the, for example, clozapine clinic, and also if somebody's in crisis. And other than that, we're trying to do everything through telephone contact. We've also been trying to keep the normal routines running. So, for example, our regular care reviews and CPA meetings, to keep those running just as normal, to try and keep some semblance of the show is still on the road. Because my fear is that if we don't, if we resort to just dealing with absolute essentials, that we are going to just be setting up a lot of problems for the future in terms of people becoming unwell, things not being attended to that we are normally very attentive to. So we've had to do that through some unusual teleconferences involving 2 or 3 phones or 1 speakerphone at the same time. It's not easy. Some service users find it very difficult, and it really doesn't feel at all helpful to be trying to have a conversation with them by phone. But for others, it's fine, and it's obviously easier if you know the person well and you can pick up the nuances through the telephone. But of course, it's not as good as face-to-face. We haven't yet quite got our video conferencing processes working for care reviews and CPAs in the way that would be helpful. Others may have mastered that already, but we haven't where I'm working. We've also had some additional help from other parts of the system. For example, the clozapine clinic and pharmacy is dispensing clozapine for longer than usual, so that if somebody goes into self-isolation, we would have time to get to them to do the necessary blood test. So we have a little bit of wriggle room there than the usual 4-week supply. Also reviewing people on long-acting depot medication, seeing if we can rationalise that to make to change the dose and give the injection less frequently. I'm sure these are common approaches that people have been thinking through everywhere. The other interesting thing is that it's given us an opportunity to talk to people a lot more about smoking cessation. We normally talk about smoking cessation at every review, and quite often people find it hard to really, engage with that. This situation is making those conversations much more pertinent. People are listening, particularly when you talk about the fact that, if you happen to be unlucky enough to get this illness badly, you're going to do a lot worse if you're a smoker. Now would be a good time to stop. And we've had a lot more uptake on nicotine replacement therapy and smoking cessation strategies than usual. The other sort of, time-consuming but important thing we've been doing is challenging decisions that seem to be rather unhelpful. For example, in some of the supported accommodation services that we work into, where staff have really been struggling with people who can't follow the self-isolation guidance. This has been escalated, and there's been talk of evicting those individuals or for trying to find some form of temporary accommodation for them until the crisis is over. And so we've had some, difficult conversations about whether or not that's appropriate. I personally think on the whole it isn't. If somebody is in 24-hour supported accommodation, being in a temporary bed and breakfast is probably not going to be appropriate, but obviously these have to be considered on a case-by-case basis. Similarly, we've had to really push back sometimes when we've had a lot of pressure from the inpatient setting to take people, and I absolutely understand the pressure that the inpatient system is under, but we've had to work together really to agree guidance on making sure that transitions are done safely in the way that they normally would be. We're not doing things that we might normally do, for example, like graduated leave. But what we are doing is making sure that the person themselves doesn't have symptoms, or it hasn't been on a ward where someone else has had symptoms, that they've completed any necessary self-isolation period before they transition out of hospital into one of our community rehab units or communal supported accommodation. And similarly, that similar thinking goes on for people who might be moving through the supported accommodation pathway, although a lot of the movement has really stopped in the context of this crisis. And then finally, we've also, of course, been trying to avoid admitting our own patients wherever possible who might be in crisis, putting in extra staff, really thinking very, very creatively about ways in which we can try and avoid people having to go into hospital, because there is a greater risk that they're going to be in the context where they may get COVID because of other people with symptoms there in a confined setting. So those are just some of the things that we've been doing over in Islington, and I'm sure some of those will chime with things that everyone else has been doing, but it would be very helpful to hear from people. Just before we go into the Q&A then, I'm going to pass over now to Sri, who's going to talk about her experiences as well. Thanks very much.
Thanks, Helen, and thanks, Connor, Fatima, for organising, and everybody on the line. So for those of you who don't know me, my name is Sri Kalidindi. I'm a consultant psychiatrist in rehab at the South London and Maudsley, and the previous chair of the rehab faculty at the college, and currently in a national clinical leadership role for something called Getting It Right First Time, where we're looking at the data across the country for rehab. Lots of you will have very kindly filled in information and data, which we will then use to support people on the ground to improve their services locally. So I think that it's really good to have this, just for everybody to get together around rehab services and think together about what it is that we can share and improve in this space. There is some good advice out there, good guidance that's being developed and has been developed and published at speed that is absolutely relevant. I know many people have already seen that. So on the NHS England improvement, website information, about mental health services. It's quite generic, but it does absolutely apply to our services as well. And then also there's some guidance around care homes on the Department of Health website too. The Royal College have developed some really good guidance, and a lot of that has been done in conjunction with other organisations such as NHS England, Royal College of Nursing, etc. So it really is about all of us coming together, across policy, across clinical services in a multidisciplinary way to develop that guidance. And what we're going to do, because there are sort of various bits of guidance, I know many of you will have read them already, but just to put them in one place where it's relevant for rehab, and I know Connor and Fatima very kindly going to add that to their website. And what we'll probably do is add it to various of the other appropriate, like the rehab faculty, and also onto the GERFT website, and make sure we tweet those out so people can have easy access to them. And then really it is, for me, when I've looked at some of this guidance, one of the things that I found most useful is just sort of to step back and think about in the NHSE guidance, they've talked about key lines of inquiry. So really thinking about what are the overarching principles, and these boil down to 4. Am I safe? Am I in the right place for my care and treatment? And that includes physical health and mental health for our group, obviously. Are my plans for my future going well? And fourthly, is everything supporting me to have the best life I can have now and in the future? And for me, this absolutely applies to staff, our staff, as well as to our service users. So that said, it's about then thinking at a very practical level of what does that mean for our services and our service users on the ground in terms of practical everyday implementation. So I think much of what Helen has said, we've incorporated as well. It's very interesting to me actually that how similar it is actually for the most part. And I think some of that kind of learning about some of the more challenging aspects would be useful to share across this group. So some of the things that we have brought in as well. So just for example, with the clozapine bloods, we've gone all the way. Our kind of pharmacy and SLAM have allowed us to go to 12 weekly bloods where people fulfil a certain criteria, so safe enough for them. And we have moved to that with the key principle of trying to reduce any kind of face-to-face to reduce the risk of infection and spread of COVID. And that's one of the things I think would be useful. We could share that as a protocol of how we've come to that and how we then make sure, even though people are on 12 weekly bloods, that we are still providing them with at least 4 weekly reviews so that we can still keep in touch with them, and also thinking about their physical health within that as well. And we've definitely increased our sort of single point of access, I think it's called in some of the guidance, availability to our care homes, to our service users, because actually our buildings are pretty much locked down. The only way people can enter our resource centres in the community is by having an appointment. And actually what's happening is our front desks are asking for who is coming in, what times, and that's the way we're doing it. Obviously we have any urgent reviews we think about on the day and fit them in appropriately. Either we visit them or they come to us, but we are obviously trying to minimise that as much as possible. So one of the things I think that has been a challenge is around people using alcohol and drugs and how we support them to make sure that they're not withdrawing suddenly, but also how do they get a hold of what they need in a way that doesn't put them at risk. So we've been having conversations with the team and with individuals about that, specifically thinking with them about how they might be able to reduce their risks of infection. And to Helen's point, actually, it's a real motivator, to maybe think differently about their current usage as well, and try and think about harm minimisation, both in terms of the COVID, but also their usage. One of the other things I just wanted to think about with all of you was how you're all keeping your staff, yourselves in your own teams, and then also the wider staff group, so our people who are supporting in voluntary sector kind of settings, how we're keeping our staff in supported accommodation, as well as possible too. And one of the things that I'm sure you've all experienced is enormous anxiety around keeping safe that people are getting. But in terms of the information and evidence that's coming through from other countries as well, so Italy in particular, what staff were really keen on was making sure that they had enough rest, had enough sleep, they had the right PPE, good nutrition, access to food. And I know it's been really great that we've had this kind of response from some of our supermarkets and so on about allowing people who are working and having to go into work, because you can't avoid it in some situations, to have that access to more easily going in and getting their supplies of food and so on. And then also coming into what we've been doing, in terms of a team, to make sure every day we are attending to our kind of team dynamics and sort of psychological well-being. So we've been incorporating things like mindfulness on a daily basis together as a team, which we did before, but I think it's been even more essential. And it's quite interesting doing team mindfulness where everybody is little screens with faces on, and everybody doing their mindfulness in that way has been quite funny, really. And then again, I think just making sure that in SLAM, for example, we've really a whole group of people across all the disciplines have got together to think about what is the offer around staff, mental health and well-being, and of course physical health. It's all so interrelated, and making sure that those are known about and talked about every single day in our team, and if people are using them, that they talk about their experience so that others can think about whether that's going to be appropriate for them or useful. And that's from wellbeing hubs where people can drop in, where that's staff volunteers are running those, where people can just sit, have a chat, refuel, sit somewhere quiet, all of those things. And that's mainly been for the inpatients, but obviously community staff can drop in and use those if they're around that space as well. And then lots of offers for staff counselling, specific lines to call into, access to psychology, access to, well, no, in particular the doctors do have access if they have sort of more either pre-existing mental health needs or emergent through this whole kind of crisis. The physicians health programme, the PHP that Claire Gerarda runs, and I know that they are actually just taking on people from whatever pressure, whatever discipline, if they can. If people are phoning through, they're trying not to turn them away, obviously. So I guess that's the main points that I wanted to make, because I think it's good to get into a bit of a discussion and take the questions. And I suppose one of the things that's really struck me in all of this is the need for clinical leadership. That's really come through for me, and where sometimes clinicians, it depends where you work, but there can be in some places a level of disengagement, disillusionment, and people feeling that perhaps the clinical view isn't being well, it's not at the forefront always. I think that's definitely been a shift here, and it's been absolutely key to make sure that stepping up of clinical leadership and using the evidence base. And as one example, we were being asked to not use any PPE, and it wasn't necessary because you can stand 2 meters away. And of course, with our service user group, it's not always easy to maintain 2 meters. People don't always behave in ways that they can be a little bit more erratic. So some of those shifts that we've made sure that staff feel safe and have perhaps, if anything, more PPE than less, so that they can get on and do their work and not feel anxious, and it doesn't impact on the sort of sustainability of their ability to come to work for the levels of anxiety. So lots more I can say, but I think I will stop there. Actually, one last thing, sorry. We are trying to think about, through GERT, through collaboration with Helen at UCL and the Royal College of Psychiatry Rehab faculty too, some more specific guidance for rehab as it's useful. So some of that will absolutely come from some of these kind of qualitative aspects of what seems to work on the ground and pulling that together, and also understanding what the mortality rate has been in this group too. Because unless we think about it now, it's going to be very difficult sort of post hoc to understand that and how our group have been impacted. We know that they have many long-term conditions, and obviously smoking as well, you know, puts them at sort of disadvantage really in terms of their outcomes. So we will be putting together something and looking at that. And obviously none of us wish for another pandemic, but there is something about understanding as far as we can the current situation, so that we can be as best prepared and as best sort of advised as we can be for future for the future. So I'm going to stop there, and I think Fatima, excuse me, we've got questions coming through. So
we do have a fair few questions. You've also been voting for the most popular questions, so we'll start off with the most popular voted questions. So the first one is, please address challenges involved in managing non-cooperative COVID-19 inpatients, especially informal.
Okay. Well, I'm non-cooperative is such a kind of tricky term, isn't it? I mean, people find it difficult to follow guidance for all sorts of reasons, because they find it difficult to take the information in because they don't understand the importance. They lack capacity, perhaps because of their mental health condition. They're acutely psychotic. They're feeling impulsive because they've got a mood disturbance. There are many, many reasons why someone may find it very difficult to follow the guidance. And so I just sort of come back to, you have to think about the individual. What can we do for this individual that is going to make it easier for them to understand the importance of what we're asking of them? And some flexibility. So I can give you an example around leave. You know, if you think about a member of the public is kind of allowed to go out to the shop and allowed to go and have an hour outside for some fresh air and exercise every day, for people in an inpatient setting, is that reasonable for them in the context of where they're at in their recovery? And all the usual things that we take into account in terms of risk when we consider how much leave someone should have. For voluntary patients, I think it's much harder, because obviously there are tight restrictions now on obviously visitors, and wards, inpatient wards are trying to limit comings and goings for obvious reasons. So again, I think it depends on how well the person is able to comply with the guidance as to how much they're able to be allowed to have more freedom in the way that they would normally on the basis of being a voluntary patient rather than a detained patient. And of course, really, you want to be trying to get people out of hospital as fast as you possibly can. So if somebody is voluntary and able to work in the community with a community support system instead, then obviously that would be the better option.
The next question, I think it's quite similar, but there might be something that you can add into, Helen. So how to balance Section 17 leave to accommodate social distancing but still try to do rehab?
Well, you know, I think that we have to sort of minimise the amount that people are going out, because we're all minimising the amount we're going out and about, and so a lot of our usual rehab activities simply can't happen, things that would normally involve obviously accessing community resources, mainstream and otherwise. So we have to think creatively about what's possible within the unit, within the setting. In our community rehabilitation units, for example, we're trying to get everybody much more interested in gardening, because we've got a little strip of garden, and trying to get people interested in taking part in weeding that and getting that ready for planting when we're able to access a garden centre and buy some plants to sort of spruce it up a bit. Within a more restrictive setting, in a high dependency rehab unit, for example, you may well, of course, need to think about things that you can do with fewer people in a communal setting, where you can ensure that there is 2 metres apart. And of course, you may need to do more one-to-one things with people where you've got individuals who can't don't find it easy to keep 2 meters apart from other service users. And of course, again, as I was saying before, this all really is dictated to some degree by the layout of your building, obviously the staffing that you've got to be able to offer that kind of one-to-one and group activity support. But there are a lot of resources being sent and being circulated on activities for people to do in 1s and 2s through an iPad. Obviously, we have to think carefully about things like board games where people are kind of touching the same counters, but we can do things through separate iPads, sort of interactively with some service users, where you have those facilities, or a simple game of, bingo. Good old-fashioned bingo. We can probably do that with 3 or 4 people in one room if the room is big enough. So I think it's kind of stretching our creativity in terms of occupations and activities and fun activities. But I think trying to keep some semblance of an activity programme going is important, because otherwise, what are we saying? People should be lying on their bed for 23 hours a day, but we really don't want that.
Yeah, I mean, I'd agree with that. I think it is about, probably quite useful for people to share what their various supported houses are doing. And certainly things like the online offers have been amazing, and some of them. So it's just about how we tap our service users into them. And I think about exercise, for example, physical exercise as well, which we know helps in all manner of ways. I think that outdoor space, when people are lucky to have that, and the earlier question about what do you do with people who are on inpatient settings, so certainly some hospital settings have good grounds, and how can we kind of think about using them better during this time, and maybe take some of our kind of social activities outside, our social programs outside as well, where they would have previously been indoors, but obviously because of the whole social distancing, using our outdoor space better and more kind of innovatively, really. But I mean, there's no easy answer. We have had people we've talked about informal here in the community setting, but people are quite unwell in extreme situations. If they're kind of more talking people down, talking people around, if they're not well enough to attend to that, then obviously thinking about medication, and on occasion maybe using sort of sedative medication more than one might normally when we're not in this kind of crisis situation, where we probably would have had maybe more staff closely nursing, and that's less of a we're less able to do that at this point in time, not least for staffing, the levels of staffing and kind of sustaining them really over the long time.
I'd also just point you to the next webinar in this series will focus specifically on inpatient rehabilitation as well. So look out for top tips from it's Raj Mohan and Sabina Berza are going to be talking about how they're approaching this as inpatient rehab consultants.
I mean, one of the things we found is making sure that our care packages in the community are keeping going. So what we have been doing is making, just phoning up and making sure that they're all going, because clearly quite a lot of our service users depend quite heavily on people coming in and supporting them around their shopping, supporting them around, sort of everyday activities of daily living. So we have really been kind of trying to think. And so some of our carers, for example, have been told by their organisations they can't get public transport, and various other kind of mechanisms they're trying to put in to keep their staff safe. So that's been, quite challenging, really, thinking about a workaround, and it has had to be having conversations with those providers of care, and then also thinking on an individual basis what we can do.
Okay, so let's mix up some of the questions. So it's been quite challenging and difficult to establish therapeutic group activities on inpatient rehab unit due to various reasons. At this time, individual cycle sessions are not happening as frequently as before in the current circumstances. I'm not sure how to support our residents with this difficult time, apart from offering regular medical reviews. So any thoughts on this?
Well, I think we've kind of touched on that a bit with the answer to the last question. You know, the thing is to try and pool all the ideas of your multidisciplinary team. Think through, what can we do? What are we doing at home with the kids? What are we doing ourselves as adults, other than just watching, you know, Netflix box sets? Are we doing anything else that we're finding enjoyable that we can actually potentially translate to this setting, which of course has different challenges in terms of people's ability to attend and concentrate, and you know, you may need to scale things down, do things for shorter times, do more one-to-one activities. But I think we have to really, to my mind, activity is always a priority in a mental health rehabilitation service. And at this particular time, it's really crucial because, as I say, if we don't attend to this and try and think creatively about what we can do with service users during the daytime particularly, then we are basically saying, you know, just go and you know, lie down. Or just sit and watch TV, and I don't think any of us feel at all comfortable with that being the only activity on offer. So you pull on your multidisciplinary team, use your own creative resources, perhaps have a whole, you know, staff team teleconference meeting about it in order to think, well, what could we try? What can we actually do that would fit within the constraints of how we're having to work at the moment? But, you know, there are things that you can do. There are activities, you know, paper-based activities that people can do, doing something, you know, on their lap, say through a computer potentially, if you have, or they have those facilities individually, if you have enough of them in the unit. There are things, you know, we just have to be much more creative than usual. And obviously, hopefully your occupational therapists are engaging in that kind of creativity with you.
Okay, so this is a comment. So there's also a challenges of encouraging some of our physically unwell people to attend physical hospitals when they also present as mentally unwell, to the extent that physical health colleagues may overlook the physical needs and redirect them back to mental health services.
I mean, I think that's always been an issue, hasn't it, in terms of diagnostic overshadowing, and clearly when our colleagues in the physical health space are under so much pressure right now, as are we, in a different way. I think it's a challenge, but again, so that's sometimes about understanding what your local pathways are, but just picking up the phone as well, you know, often just speaking to whoever the medical registrar is on call, or if you have links with any of your, you know, the sort of consultants and so on, and just asking for specific advice. And if you can, support the person, you know, in your own unit, because often they'll get better care. And obviously, if you're again now taking them into an A&E setting, or you know, any of that kind of acute hospital settings, there are likely to be kind of, you know, I know they've split up, haven't they, often into two pathways. They're kind of hot and cold, or I think they call them dirty and clean, which isn't very pleasant language to use, but you know, that's the kind of NHSE language in terms of pathways for patients when they're going in. But you are going to expose them to more risk of getting COVID as well. And I think that has to be the priority right now, because our people, if they do get that, are absolutely going to they're going to be at a disadvantage often with their long-term conditions, you know, and lifestyle issues as well in terms of their outcomes. So I don't think there's any easy answer, but just to really be proactive and phone people and ask for advice if you can, rather than taking them into that space. And again, you know, and the government advice has been clear, if they need that input in the acute physical health setting, they need to go there, and they you know, whatever care can be given, they will need to get it. And that's often what we do, isn't it? Advocate as well, and be really clear. Yes, they're mentally unwell, but they also have, you know, X, Y, and Z. And we often find, so in my own team, we will liaise very closely with our psych liaison who are in that site. So it's really clear that mental health side is being supported, but they are there for their physical health that also needs to have treatment, you know, investigations and treatment, and we'll liaise very closely for that reason, but also because the psych liaison team won't know, obviously, our patients who are quite complex very well, so we can advise and support in terms of what we need to happen on the mental health side to keep them as well as possible and improve their treatment from that aspect too, whilst they're in that physical health setting.
Okay, so this question is asking for some, I guess, look into the future. So in our locked rehab ward, the focus has moved from community-based activities to increased activity within the unit. For longer stay patients, this is an improvement. How do we hold on to this once this has all passed?
Well, I'm afraid I can't resist saying that there's no such thing as a locked rehab unit. That's not a term that the college are in support of people using, because it doesn't have any specifications. So I assume you actually mean a high dependency rehab unit, perhaps with higher staffing, because you may have people who have particularly challenging behaviour. Anyway, that aside, I agree. I mean, I think if you've found a way to engage people in more activities in this context, that's fantastic, isn't it? And you absolutely don't want to lose that. So trying to bottle it, thinking about what did you do? Was it about the fact that service users were, you know, more receptive because of the context to doing things, or was it that you were all thinking more creatively as a team because you were so aware of these issues we were talking about before around the need to make sure that people are entertained, and hopefully within that you can do activities which are not just sort of fun but are also helpful in terms of people improving in all sorts of aspects in relation to particular mental health difficulties and functional impairments that they have. So congratulations. I mean, I think it's great that you've managed to do that, but you have to really sort of try and work out what it is that has changed in terms of your usual practice, and absolutely keep doing it.
Okay, so a lot of these are quite similar, so I'm just going to pick one or two that you can extend on, Helen. It seems hard to recommend the usual graded transition visits with regards to COVID issues when discharging from inpatient rehab to supported living. Any advice or best practice guidance?
Yeah. So my take on this is that we should not be doing graduated leave. I think that coming and going between sites is just not acceptable in this context. You're putting people at unnecessary risk of picking up COVID. So what we've had to do is to reprioritise our kind of discharge planning to make sure that we can discharge somebody ideally in kind of one go without our usual graduated process. And so that might mean that, for example, we put somebody on Section 17 leave for a week to the setting where before we would have done a graduated process that led to their full discharge. So it's doing things slightly differently, but I would very strongly advise against continuing graduated leave where people are coming and going between settings. I think that's an unnecessary risk at the moment.
I mean, one of the things that we have done, I'm just thinking about one of our service users who are discharging, who has a lot of anxiety around any transition, as lots of our people will, is we've just shown them, you know, using a iPhone around their new placement, and they've just sort of met people that way who they're going to go to the placement and be in. So that's been, I mean, that worked quite well. You know, it's not a sort of solution for everybody, but just in terms of, you know, helping people to think about where they're going to and feel a little bit less anxious, and bring some familiarity before they actually step into that environment.
Okay, so we've got time for just one more question, and this is again just something to add to, quite similar to the previous question. So how do people hold the balance between managing risk and supporting recovery when risk can become predominant in our thinking because of COVID, and we can lose the track of people who are becoming more stable?
I guess what I've kind of learnt through this last 4 weeks is that really what we have to do is to continue to apply quite a lot of our usual thinking. And in rehab, our usual thinking is quite creative, because we're often trying to think through what's going to work for this person at this time when other things haven't worked, which is kind of why they've ended up coming to rehab services. Otherwise, they would have gone home directly from an acute ward, say. So I think you have to not stop thinking in the usual way. You just have to add to it the COVID risk. So you shouldn't be taking unnecessary risks with someone, but at the same time, if you can, I was talking about trying to, you know, avoid admissions, trying to think more creatively, is there anything additional that we could do that we wouldn't usually do to try and keep somebody at home to try and work with them through their crisis. And you might conclude that there isn't. It might be that you can do something, that there's something you can do around either their medication and or additional staffing, additional visits that could be helpful, that would allow you potentially to get through the crisis. But obviously you have to balance that against the risks, and the risks in this case are not just our usual risks of them not coming into hospital, but the risks of going into hospital, or as we were talking about in the other direction, the risks of somebody coming and going as part of a discharge plan are higher than the risks of them going in one foul swoop. So I would say that we must continue to think in the way that we always have, that we must not lose that ability. And I think that's part of what's been happening as I've experienced it, personally, but also in people I'm working with, is that because we're under enormous pressure at this time, and because we are, really dealing with a huge amount of change and accommodating different processes and trying to absorb new policies on a daily basis, it kind of stops people thinking sometimes. And so creating a space where you can step back and just actually have the time to think again is really important. And I think those sorts of regular structures that we usually use in our clinical services for reflection are really important at this time as well, so that you're not making knee-jerk decisions. You're actually thinking through, as you always would as a good clinician, all the risks and benefits before you make an important decision with someone or about someone.
Yeah, absolutely. I'll just add to that the person often has their own kind of views, and just to think with them about, make sure that we're thinking with them about what the options are and weighing that up, and giving. Often our decisions around risk are based on what that person understands, the level of capacity and the level of willingness to engage in certain options or not. So which is what we always think about. So I think that's really essential at this time as well. And the other point to make actually around some of this is thinking about making sure that we're continuing to advocate for this group. I've heard some examples around the country because of the whole COVID situation, that rehab teams are being actually just brought into a kind of generic way of working in the community, because there are concerns about staffing and sustainability over this period of time. So I guess again that's where the clinical leadership comes up. There may be some changes that are required for operational reasons to maintain services. Equally, this group of people do need to have our support, and really to make sure that they're not kind of forgotten about or disadvantaged, when sometimes in a crisis such as this, they may not be uppermost in people's minds. We see that anyway, a huge focus in all of our trusts on the acute pathways all the time, so how do we make sure that we advocate and keep our group in mind too, and make sure that others do?
And Fatima, can I just wanted to say one last thing before you finish, which is,
yeah, we've got one burning question as well, Helen.
Okay, well, I guess I'd just like to sort of get this in really, which is that this awful situation, the awful kind of situation that we're all dealing with every day at the moment in our personal lives and in our work lives, it's also really brought home to me what a fantastic group of colleagues I have. I cannot sort of understate how wonderful it's been to work with people who are so professional and so committed to working with this really complicated client group. It's really has been, well, it's been a joy in the middle of what is certainly not a joyful time. So thanks very much, everyone.
Thank you. I'm so sorry we can't take all your questions. We will have a couple more webinars throughout the next couple of weeks, but if we need to, we can perhaps repeat this in the next couple of weeks too. Final question, burning question. How do you decide what is essential work for community rehab under the current circumstances?
Well, I think you start off with obvious things. What cannot be done through a telephone or a video conference method. and that's obvious practical things, taking bloods for people who can't go to the clozapine clinic for whatever reason, or giving depots. But it's more, and seeing people in crisis. But I think that list of what is absolutely essential is something you have to discuss in the team in order to, as you normally would, again, to think through, well, this person needs X, how are we going to do that? Can we do that without actually a home visit? And if you can't, then it's an essential thing. If it's an essential thing, if they need it to stay well, then you have to think about how you're going to get that to them, either you or someone else.
And I'd just add to that. Sorry, go on, Helen, have you finished?
No, that's fine.
Yeah. Just to add to that as well, that I think obviously it's just so new for all of us, and there's been it's almost like thinking about those phases that you put up earlier. We've just kind of been finding our feet and doing the initial thinking about how can we get all of this set up, what is essential work. But as this goes on, that will potentially change, because what we'll be thinking about is more, how do we keep people well, and how do we not store up more and more as we're coming out of this whole kind of crisis. So the hope is, I think, that we do the essential stuff now, but what is essential may expand as we go through, and things are more settled in some respects in terms of our ways of working. Everybody now having access to VPNs and so on and so forth. That's that kind of flurry of activity that needed to happen to get things to work differently in this current crisis. But as we go through, I think we may be able to expand what we see as essential work. That's my hope, and obviously that'll be dependent on all sorts of factors, including how well our staff are able to remain in order to maintain a good service.
And I think to add to that, Sri, that a lot of what we do is essential. If we stop making contact with our service users, if we stop checking in with the staff in supported accommodation in the community, things are going to fall apart. So, we may have to do it differently, but we should basically be trying to do the things we usually do, but we just may have to do them in a different format for a while.
Absolutely, and what we've been doing, even though we've been, for the most part, as far as possible, running a skeletal team on site, covering those sort of face-to-face aspects that can't be done over the phone, and etc. But everybody who's working from home, absolutely, we talk about it feeling busier than ever, because we are still running our CPAs virtually, and running our reviews. All of that stuff is still happening.
We're not getting any time in the kitchen for a quick chat and a cup of coffee. That's the trouble.
Brilliant, thank you. So that concludes the session, and a huge thank you to our wonderful speakers for delivering this session. And honestly, we've got so many questions and I'm sorry we couldn't have enough time to, I guess, answer all of them. If you want to forward this this video to your colleagues, you can do so. We'll be working hard to get it on our website, and I think from Monday afternoon to the latest, maybe even if we can get the IT teams to help us this afternoon, and then you can share it with your colleagues, those who aren't able to join us. So we do have a lot of other webinars planned. So for the next couple of weeks, we've got a couple of webinars to help, I guess, as well as carers, but service users as well. And we also have an inpatient session that's going to be led by Dr. Sabina. So lots to look forward to. We also have, we're also doing something a little bit more intimate for our Ames Rehab members, which is called a reflective space. And this is just to enable members to join in, have a chat with each other, share ideas, or share how they're feeling and how they're getting on. It's hugely informal, and we've got 3 sessions scheduled in. I guess depending on the popularity, we could extend that, but at the moment spaces are limited, and it's currently available to our Ames Rehab members only. And of course, there's lots of other resources within the college. As Sri mentioned, the college is working really hard to produce guidelines as we're going along this pandemic. So a huge thank you, and please provide us with feedback if you've enjoyed it, or if you think there's further things that we could be discussing and addressing for you. Thank you.
Thanks very much.
Thanks, everyone.
Bye bye.